So today we are going to understand the atrioventricular block, the AV block. Basically the idea of the AV block is that there is delay or interruption in the conduction of the atrial impulse, or we can say the supraventricular impulses from the AV node. And basically there are three degrees of the block: the first degree, second degree, and the third degree, based on how much the impulse cannot pass. And the first and the second degree being the partial or the incomplete AV block, while the third one being the uh, complete AV block. Now, before we move any further, we must understand the PR interval. What is PR interval? It is the interval from the beginning of the P wave to the QRS complex. And as you can understand that P wave represents the atrial systole, so it should include the PR interval should include the time of the impulse to travel from SA node to the AV node, and then it is up till the start of QRS complex. So till that time, the impulse reaches to the AV node and the bundle of His, and then to the bundle branches. That all those things are represented in the PR interval. And normally the PR interval is about 120 to 200 milliseconds. And that's what we are going to see ahead, that when this PR interval increases greater than 200 milliseconds, then we suspect the AV block. Now the first degree AV block. Basically the AV block, this is partial or incomplete AV block, and there is delay in the conduction of the atrial impulse or the supraventricular impulse from the AV node. And as I've already mentioned, that PR interval is prolonged, that is greater than 200 milliseconds. Then a rule over here, or we can say the one thing to be kept in mind, is that all P waves are followed. This is a must thing, that all P waves are to be followed by QRS complex. Now, what are some etiologies behind the first degree AV block? So usually the AV block can be physiological. Now this is thing to be kept in mind, that first degree AV block is usually most of the time benign, and it is physiological, and that is due to the increased vagal tone or due to the age-related degeneration. But it can also be pathological in the myocarditis, or when we are using some AV blocking drugs like digitalis and all. Okay, now second degree AV block. Now the idea here is that there is intermittent interruption of the atrial impulse, and as you can imagine, that P wave is not followed by QRS complex. So if we have this P wave, then we have this QRS complex, then again we have T wave here, then we have P wave, then QRS complex, then we have T wave again, then we have one P wave that is not followed by QRS complex. Okay, so here we suspect the atrioventricular block, so a second degree AV block. And this phenomenon over here, that there is no ventricular beat or QRS complex, is called as drop beat. Okay, and some people do take out the ratio between the conduction to the drop beats, so we have 2:1 conduction. Usually we should avoid this. I have written it by mistake. We should avoid the 2:1 because it is a separate entity, and I will tell you why this is a separate entity. Okay, now so we can have something called 3:2, 4:1, even 3:1. Okay, now let's see the types of the second degree AV block. So two types of basically two types. There are two more types: 2:1 type and the high grade AV block type. But for our purposes, we must understand the Mobitz Type I first and Mobitz Type II. So in the Type 1 block, we have something called Van-Back phenomenon, and Type 2 block is the atypical one. We are going to see both of them now. Okay, in the Mobitz type 1, we have this progressive increase in the PR interval, and this phenomenon is called as the Van-Back phenomenon. So what happens in the progressive increase in the PR interval? The idea here is that we have PR interval, then we have QRS complex, then T wave is there, then again P wave, then QRS complex, but now again we have P wave, and then we have QRS complex, and then finally we have P wave, which is not followed by the QRS complex. So can you see what has happened? Here the PR interval was this much. Now the PR interval has increased, and finally the PR interval has increased more. Then we have the drop beat. So this is 3:1. We have three P waves followed by QRS complex, but only, and then a one drop beat. Okay, so progressive increase in the PR interval followed by a drop beat. This is Van Beck phenomenon. Now we can also define it like this, that there is progressive decrease in the transmission until it fails to form a until the transmission fails ultimately, and then a drop beat is formed. Okay, now Mobitz type 1 is usually having a good prognosis, and usually it is benign, and it is most of the time due to the AV nodal pathologies itself, in the AV node itself. Now the Mobitz type 2 is when there is no Van Beck phenomenon and the PR intervals of all conducted supraventricular impulses are constant. Then what is different? We have abnormal or intermittent absence of the QRS complexes, and that is what I have written over here, that there is no preceding progressive prolongation of PR interval, that is the Van Beck phenomenon, and the drop beats occur randomly in between. Now the etiologies behind this is usually due to the problems in the distal conducting pathways and his or the Purkinje fibers, and we are going to see ahead in the lecture that the Mobitz type 2 is can be a result during the acute coronary syndrome or after the myocardial infarction. Now, what is the appearance of the ECG in the second degree block? So, as I've already stated, that there is progressive prolongation of PR interval, that is the Van Beck phenomenon, and the narrow QRS complex, because the QRS complex is narrow here, but in contrast, we have wide QRS complex in here. And can you imagine, can you just think something for this thing? The way I remember is that the wide QRS complex is because we have, I recall I have said that there may be pathology in the bundle of his or in the Purkinje fibers. And if we have something bundle branch block like mimicking conditions, then you recall that I have already stated in the QRS complex video that we have M-shaped or anything, but we have prolonged QRS complex and widened QRS complex as a result of bundle branch blocks. Okay. Now, the next thing in the type 2 is also that we have intermittent dropping of the beats and constant PR interval. No Van Beck phenomenon. Okay. Now, the third entity of the second degree AV block, as I mentioned earlier, that is 2:1 AV block. Now, why do we do not consider it in the type 1 and the type 2? And that's simple because, if we have P wave every alternate, coming every alternate time of the QRS complex, this is T wave, and then now P wave is not followed, and then again we have a P wave that is followed by QRS complex, then how can we differentiate it based on only two waves, two QRS complexes, that it is in the Mobitz type 1 or type 2? At least we need something more for differentiating in between the Mobitz type 1 and type 2, and that's what I've mentioned it here, that they cannot be differentiated from the type 1 and the type 2, and every alternate supraventricular beat is blocked. Now, what is the clinical significance of the second degree AV block? And usually the second degree AV block, the Mobitz type 2 specifically, has pathological etiologies, that is rheumatic carditis or acute coronary syndrome disease. Then drugs, obviously the beta blockers, calcium channel blockers like verapamil and diltiazem will have the AV block effect. And yes, the digitalis, very important. Digitalis readily shows a second or second degree or first degree block, AV block, with the digitalis toxicity. And question can be asked that third degree AV block is caused by digitalis. Rarely. The digitalis usually causes second degree or first degree block. Okay. Now, another principle over here is that the AV block is a protective or physiological in atrial flutter. In atrial flutter, what happens is that because of the reentrant loops, the atria contract again and again and again, and at a very high rate, that is about around 300 to 400. And to prevent this high rate, that is supraventricular impulse, to move to the ventricles, there is blocking at the AV node, and hence it prevents the ventricular tachycardia or the ventricular fibrillation like conditions. Okay, so important in the atrial flutter that second degree AV block helps to prevent the ventricular fibrillation or tachycardia. Now the ventricular Now, the last point is that we have the Mobitz type 1 is usually benign, as I've already stated, while the type 2, Mobitz type 2 carries an adverse prognosis. Okay. Now, the third degree AV block. Third degree AV block is called complete AV block. Okay. Now, the complete or the permanent interruption of the AV conduction. And now what is happening is that no conduction of the supraventricular impulses or atrial impulses to the ventricles. And what would happen, can you imagine? Yes, of course, the any other pacemakers. Now heart has many pacemakers because the SA node fires at the highest rate, so it becomes the pacemaker. Now if no impulse arises to the ventricles, obviously the ventricles would escape by having some pacemaker rhythms. Now different pacemakers can be there. The pacemaker cells can be either the His bundle of His, or even the Purkinje cells, or even the ectopic ventricular tissue cells itself. And the phenomenon is called ventricular escape. Okay. Now, and the beats are called ventricular escape beats. Now, obviously, the ventricular escape beats and the sinus node rhythms would be different. So we have something called asynchronous sinus and ventricular rhythm. Now the ECG findings in the third degree AV block, we have AV dissociation. Yes, there is no relation between P and QRS complexes, and that's because we have two different pacemaker cells, that is SA node at the top and the ectopic ventricular pacemakers, be it the bundle of His or Purkinje fiber or the ventricular tissue itself. So there is no relation between P and the QRS complex, that is I'm saying atrial systole and the ventricle systole. They occur at their own pace, at their own rhythm or the pace, okay, rate also. Now we have of course slow ventricular rate, and that usually that is 30 to 40, and this is feature of ventricular escape beats. Okay. Now we have the near normal or bizarre slurred QRS complex, and can you imagine why we have this QRS complex bizarre or slurred? Yes, that's because if there is some MI or anything like condition that causes the third degree AV block, then we have the pathologies associated with the bundle branches also. And if we have pathology associated with bundle branches also, then of course it would mimic a bundle branch block and would causes a slurred or enlarged QRS complex. Okay. Now the regular PP interval, regular RR interval, the interval PP interval less than RR interval, and varying PR interval. These are the four criteria or features that qualify the diagnosis. You can remember these also, but this is something that is mentioned in the text, and you should know it for to qualify a diagnosis of a complete AV block. Now the important principle to understand over here is that about the Stokes Adams syncopal attacks that occur during the ventricular asystole. And how can the ventricular asystole occur? Yes, it may occur because of the third degree AV block, and of course it may occur because of the sluggish pacemaker of the ventricular tissue, and this may also occur when there is transition between the second to the third degree AV block. Now we know that there are different ventricular tissues, and it is not hard to imagine that there may be two ectopic foci which may be having their own pace, and when they have competition between two pacemakers, so during that time also we have ventricular asystole. So how to define the Stokes Adams syndrome? So important thing to keep in mind is that syncopal attacks occur usually in the ventricular asystole, but not all of them are Stokes Adams syndrome. Stokes Adams attacks. Stokes Adams are only said when they are accompanied by the third degree AV block, and when the third degree AV block would occur when there is failure of the ectopic pacemaker cells to also discharge. So at that time the ventricles won't contract, and that would lead to asystole, and that would lead to syncopal attack, and that is called Stokes Adams syndrome, Stokes Adams syncopal syndrome. Now, a feature of the Stokes Adams syndrome or other syncopal attacks is the giant T wave inversion. Now, these are very large, bizarre inverted T waves, and they have prolonged QTC interval. Okay. Now, what is QT interval? QT interval is the interval between the beginning of the QRS complex and the end of T wave. And as you can imagine, it is the phase of the ventricular systole and repolarization. So that would the any pathologies that occur in the ventricular conducting system, and all those things would ultimately lead to a giant T wave that would lead to syncope. So these two are the features in the syncopal attacks, and also in the Stokes Adams syndrome, as we have discussed that in a previous slide. Now, the giant T waves are typically seen in the V3 lead, okay, and this is something that you should keep in your mind. Um, and this giant T wave inversion are almost the pathognomonic features if when preceded by the syncopal attacks, that there may be some underlying pathologies if these giant T wave inversions are seen after a syncopal attack in the ECG. Okay, so now we see the clinical significance of the third degree block, and we have various pathologies like Lenegre's disease and Leff's disease, both of which usually have unknown cause and an origin, but uh, Lenegre's disease have sclerodegeneration of the conducting system, while Leff's disease have fibrocalcareous enrichment of conducting system. Both are age-related degenerations, so sometimes we together call them Lenegre-Leff's diseases. Okay. Now, the intracardiac surgeries also cause the third degree block, and of course, the digitalis intoxication is there, but it is rare. The digitalis intoxication would rarely cause a third degree block, but readily cause a second or first degree AV block. Okay, and yes, of course, the coronary artery disease, or even in case of the acute MI, that if there is a damage to the uh, post bundle of His or the Purkinje fibers, that would may appear like a third degree AV block. And usually if there is a AV block complication, the third degree AV block complication in the MI, then that has a worse prognosis. Okay. Symptoms of the atrioventricular block are usually fatigue, dyspnea, chest pain, and syncope, but these are not seen in the Mobitz type 1 second degree block and even the first degree AV block, but these are mostly seen in the third degree AV block or even in the Mobitz type 2. So yes, the severity increases with the degree of blockade. Okay. Now, what are the treatment options we have available for the AV blocks? Yes, we need to identify the cause for the AV block. If there is some, of course, we cannot do anything for the Lenegre-Leff's disease, but if we have something underlying pathology, then we can treat that thing, and we must increase the heart rate if there is the third degree AV block, or even in the uh, second degree AV block sometimes. So for that we use the antimuscarinic drugs that block the M2 receptors, and that help to increase the heart rate. Now we must pace those ventricular cells to have them synchronized together for efficient depolarization. So we use transcutaneous pacing, that is the pacemaker under the skin for pacing the ventricular cells, and we may also use the permanent pacemaker in the severe cases. So now let's see the real world ECGs of the AV blocks, and I have included links of all these ECGs in the description below. Uh, okay, now what is in the Mobitz type 1, can you recall? Yes, in the Mobitz type 1 we have the Vennebeck phenomenon, and in this we can see that we have the PR interval being prolonged. Look here closely, and the PR interval is getting prolonged, and yes, then we have this absence of the QRS complex, and that is we call it dropped beat. Okay. Now in the Mobitz type 2, we actually I could not get the best figure, best ECG for the Mobitz type 2, but the thing you can understand is that we have uh, normal or constant PR interval. Okay, we have normal or constant PR interval, you can see everywhere, so that feature you can see. And wide QRS complex I cannot show because this diagram doesn't have it. Okay, but keep that in back of your mind. Okay, in the Mobitz type 2, and no Venn-Beck phenomenon because PR interval is constant every time. Now 2:1 type of the second degree block. Now can you see that we have this P wave and this is QRS complex, but now we have dropped beat over here, not followed. Then again we have P wave, then QRS complex, then we again have drop beat, Then again we have P wave, QRS complex, and then not followed by. So we have something 2:1 ratio, two conduction and one drop it. Every alternate P wave is not followed by QRS complex. Okay. Now what happens in the third degree AV block? Can you recall that ventricular cells obtain their own pace, and so we can see that we have the very slow ventricular rhythm, and you can see that there is a long gap between the two beats. Okay, and sometimes we have this P wave followed by the QRS complex. Sometimes it is very close, so a very abnormal PR interval is there. But in contrast, we have actually we see a 1, 2, 3, 4, 5, 6, 7, 8, 9 boxes in between every time. 9 boxes every time in between the QRS complex. So it shows a normal normal RR interval and normal PP interval, but abnormal PR interval, and that's what I have mentioned in the slide previously for the diagnosis of the third degree block. Finally, I've kept the T-wave inversion, that those are the giant T-waves that are inverted and typically seen in the lead V3 over here. So you can see that we have these inverted T-waves and they are so giant. And these are when the ECG is plotted and they are seen after a syncopal attack, then usually we can say that that may be due to the third degree block, or the underlying pathology can be thought due to the heart. Okay, so with this we have concluded our lecture on the ECG of the AV block. Hope you liked it. Subs if you loved it, and do subscribe and share the video if you liked it. Bye.